Good morning again. It's a pleasure for me to present about the delayed access to different tests and its impact on the evaluation of eligibility for hepatitis B treatment in Burkina Faso. A word of background. Burkina Faso is a country with high prevalence of HBV. In general population, the prevalence is around 9.1%. The deaths related to HBV are very high, more than 500 deaths per year. In Burkina Faso, costs of care are expensive and paid by the patients. This is why we must have efficient monitoring of fibrosis to avoid complication and then death. Who targets to be achieved to eliminate viral hepatitis as a public health issue by 2013 is to 19% of people living with hepatitis B must be diagnosed, and 80% of people eligible to treatment must be treated. Treatment eligibility assessment require many exams, which explore viral replication, liver fibrosis, and liver inflammation. But in resource-limited setting, access is frequently limited for HBV, DNA, and FibroScan due to the cost. There is many treatment criteria: EASL, WHO, TreatB, and HepsaNet. These criteria assume that all the tests are available simultaneously at the same moment, but in real life, it is not the case. People pay and exams come one by one. So we want first to describe the delay in completing each test in real life and to estimate the diagnostic accuracy of WHO 2024 April to diagnose significant fibrosis compared to FibroScan, then to evaluate the impact of the time interval between APRI test and FibroScan on the discordance of a result in staging liver fibrosis, and then to assess the concordance between the different treatment criteria compared to EASL in the diagnostic accuracy. We done a retrospective cohort study, and we recruit all patients with chronic hepatitis B coming to consult with the hepatogastroenterologist. Data collection was done during 8 years, and at the first consultation, 5 tests was administered: HBV DNA, FibroScan, e-antigen, transaminase, and plaquette count. We realized Kaplan-Meier survival analysis, and the event was test completion over 3 years of follow-up. We estimate the sensitivity and specificity and the impact of the delay, and we use the Cohen-Kappa to assess concordance between the different criteria of treatment. Main findings. The median age was 34. Male was most represented, and 26% of people was at the first consultation in the hospital. The median time for completion was 400 days for all the exam. Here we want to show you that even if we see that ELT is the most relied exam because it is not expensive, after 1 year, people continue to realize FibroScan and viral load, even here because we are in urban areas. So people continue to realize if you give it and you prescribe the exam. Concerning the impact of the delay on APRI diagnosis accuracy, the longer the delay in APRI testing, the lower its sensitivity and specificity. And concerning treatment eligibility, we see that TreatB and HepsaNet have a better concordance with EASL, but a low concordance we find with WHO 2024 because it's leading to overtreatment. We find an impact of the delay on APRI's diagnostic accuracy. Healthcare professionals must encourage to complete HBV DNA and FibroScan in urban areas. TREAT-B and HEPSANET score must be better alternative, might be better alternative in our context, and we must increase access to diagnostic tests and treatment. Thank you.